So I'm glad to hear it. All right, welcome, welcome, welcome. Thanks, guys. Again, everyone that was in this room to begin with, thank you for your patience. For folks that were in the other link, apologies for that mix-up. We're trying to clear out all those old links to our old Zoom account. So just as a primer for folks, since we're hoping that you'll be coming back to us over the course of the next few months, if when you see the link on the Zoom and it says edu, then that is the wrong link. We want the gov. Zoom gov is going to be the one moving forward. So just so everyone knows, if you go into the edu or the education link, it's not going to be working anymore. So just wanted to give that primer. We'll put that out in an email to make sure that everyone is aware. So Janelle, yes, I can see you waving. I'm not sure if I can help with your sound or not. So but welcome again. Today's session is on an introduction to data. And this is the third in our series. And so the objectives here are to define and identify the differences between quantitative and qualitative data. We want to define and interpret different types of quantitative data that are listed here. We're going to very briefly describe the process for collecting and analyzing qualitative data. And then we're going to kind of wrap up with looking at different types of visualizations, because you're going to be able to kind of see those oftentimes in public health literature and otherwise. And then finally, I want to wrap us up with a conversation about roles and responsibilities and how data can help you as community health workers to continue in your performance of your own duties. So in terms of key terms, these are terms that we're going to be using throughout the next hour and a half. Yeah, Kimberly, I see you're saying that we've tried to let folks know that this is the new link. So key terms are quantitative and qualitative data, percentages, rates, incidence, prevalence, pie chart, bar chart, and line graph. We'll be going through each of these in kind of a little bit more detail over the course of the next hour or so. But I'd like to begin with this conversation around, like, generally speaking, quantitative and qualitative data. And so I want to start with this. And so please feel free to unmute and share or just throw something into the chat. What are data? Who can help me with a definition of data? What do you think about when you hear this term data? Yeah, Janelle? Anybody?
I would think it's information that you gather from an event or an initiative, some kind of survey.
Yeah. Yeah, information, right? So in the chat, I see quantitative results, captured information, survey results. Any other thoughts on what data are for folks? Yeah, information's collected for a purpose. Good.
Success stories and other like focus group information.
Yeah, right. And I appreciate that, right? Because now you're kind of differentiating between quantitative numerical data and qualitative non-numerical data. So we'll talk about that in a little bit more. Thank you guys for all this stuff coming in, all the chats. How do you currently use data in the work that you do?
We use it to. Oh, go ahead.
At Texas Health, we use it for everything we do. We give grants based on community-based organizations data that they've collected. We use it to drive what initiatives we move forward with, etc. It's part of our life.
Everything, right? Grant writing, tracking outcomes, right? Complying with grant requirements, quality control. Yeah, lots of good stuff coming in here. Insight patterns. I appreciate this. Okay. Anybody want to share their own experiences with data, whether it's collecting data, managing data, reporting data, or providing data? If you've ever been a survey participant, which I'm sure everyone here has been at some point in their time. Anybody's experiences, good, bad, indifferent?
I was just going to add, as a contractor, you usually have reporting requirements. So you're collecting data and everything that you do to meet those contract requirements.
Yeah. Got to prove that you're spending the money the way that you said that you would and that you're achieving the outcomes that you said that you would. Marquita says community health needs assessments. Yeah, right. So important to help us understand the current status in the communities that we're serving.
Jason, I just want to point out Adonis's comment, which is let's not forget about the humanity behind the data. Those are people. And I
Yeah.
think that is a theme of your presentation.
Yeah, exactly,
Workshop.
right. I think, and this will kind of come back around when we start to wrap up here, is that, you know, data are people's lives. There's people's stories, whether it's quantitative or qualitative data. And because of that, we have a responsibility to collect it in an ethical way, to manage it and report it in an ethical way, because ultimately it is not just a number, but it is somebody's life that we're actually describing. So with that kind of in mind, let's think about how data can help our communities. We've already talked about kind of community health assessments and otherwise. What are some of the ways that data can help?
I think it can bring in needed services. I mean, I think about like when I go to like Academy or something and they ask for your zip code. So they're seeing how far people have to travel for services. So that's just a very simple way, but it could be used to create or determine what kinds of services to provide.
Yeah, great. And then I see in the chat, tracking needs, allocating resources. Man, it's coming in fast. You guys are quick.
It paints a picture.
Yeah, thank you, Bill. Yeah, it's this idea of kind of understanding where we're currently at, determining needs. I also think it can tell us, it can give us a lot of insights into strengths and where we can build upon things. I see somebody put, Yvette talks about tracking languages spoken, so important. So now I want you to flip it and think about how can data potentially harm the communities that we work in and serve?
If it's not accurate.
Can you explain a little bit more, Lan? I'm going to put you on the hook to kind of go a little bit deeper on that. What does that mean?
Sure. If you're gathering data in a group that doesn't speak the same language, doesn't have the same reading level, feels intimidated to report for some reason, you may not be gathering accurate data.
Yeah, so it can be a misrepresentation, right? It's this idea of I want to understand, you know, the impact of a certain program on men living in a certain zip code, but if all you collect data from is women in that zip code, then you actually have no idea what the impact is, right? So it's like, how do we actually tell the story in a comprehensive way? Any other thoughts folks want to share? And I see a lot of things in the chat, which I'll call out.
I know that when I was going over the videos of the webinars, it was mentioned about incentives and how the results can be biased. If we were to give like incentives to members of the community, like I did for their surveys and
Yeah, so I mean, depending upon the community served, and I would say for any community, if we're going to ask them to participate in research, we need to compensate people for their, not just their time, right, but for their expertise. This is a key piece that I always want to land on, is we often say, oh, I want to give you something for your time. No, you're sharing your knowledge, you're sharing your expertise as a community, and we need to reframe that. But to Jessica's point is that you can then potentially create a bias if your compensation is too low. So maybe you only get people who are willing to kind of participate because of that, or maybe it's too high and then you're going to get two people that are coming in for the wrong reasons. So you can get some sort of bias there. Lots of things in here. Rural communities versus urban, right? Making sure data collection are not funded by an organization that has a stake in the result. Thank you, Susan. Yeah, so there's all sorts of ways that data can be a misrepresentation. You can create biases. You can create additional disparities if we're not thinking about this appropriately. And this is part of why we wanted to have this session for community health workers, because oftentimes you, as the like tip of the spear, are asked to either help with surveys, collect data, encourage people to participate in data, and we want to make sure that you guys are well equipped to be able to advocate for the most appropriate, ethically appropriate data collection and research possible. So I want to thank everyone for your participation. We're going to kind of keep engaging in this as we go, but I wanted to just kind of level set with some of those pieces before we jumped into this. So we're going to start with quantitative data. So you already mentioned in a prior piece of this discussion, quantitative data are kind of things that we can count or measure using numbers. And when we think about quantitative data, I want you to keep in mind that there are two main types of quantitative data. And these are key terms that you'll hear oftentimes. There's a discrete data. These are items or numbers that can be counted, right? They don't have to be in any sort of order, but an example of a discrete quantitative data is the number of people in this webinar session today. We can count it, and that is a number. We can also think about the number of people with diabetes diagnosis in South Texas, right? That is a discrete number. That's different than a continuous number, and continuous numbers are data or numbers that fall in a sequence or order, right? And they may have an infinite number of possible values depending upon the scale or the thing that we're looking at, right? So examples of a continuous data point are age, our weight, blood pressure. Those are on some sort of a scale, and each of those numbers means something that is different, and they can be counted and enumerated in a different way than those discrete numbers. So at the end of the day, quantitative data ultimately help us count things. They help us understand two primary things: how big an issue is, right? So if we're counting the number of people in Texas that have diabetes, but we can also begin to understand the spread of an issue, right? So we can know that there's a certain number of people in Texas that have diabetes, but that we can also look at how many counties in Texas have more than 25% of the population with a diabetes diagnosis, right? So it may be that all of those people with diabetes live in one place. Not likely, right? But once we begin to see the spread, then we can see how big it is, and is it all concentrated in one place? So again, discrete and continuous data points are our main things when we think about quantitative data. This is opposed to qualitative data, which is information or data that are based upon words, right? So you can't necessarily easily measure or count qualitative data. It includes stories, it includes pictures. Oftentimes, these are the most kind of common data that you as community health workers will engage with, right? One of y'all's superpowers as community health workers is being in the community and listening to people's stories. Those stories are data, whether you think about them as that or not, but you're sharing those stories with others. Those are data points that people rely upon to make decisions, right? So qualitative data oftentimes helps us describe or explain things, right? So if we think about numbers as counting and giving us scope and scale, qualitative will kind of explain the why. So again, if we think about our diabetes example that I've been running with, it may be that there's 25 counties in South Texas that have high rates of diabetes. That data doesn't tell us the why, but we can go and interview people. We can go and interview stakeholders, leaders, community members to try to understand, well, why is it that so many people in these counties have diabetes? And then you get to understand the why behind the data that you're seeing. So oftentimes we'll use qualitative methods when we're researching a new topic, something that we don't necessarily know a whole lot about, when we're trying to explain the why, as I was just describing, or when we want to learn the lived experiences of people that we ultimately serve. So again, those are our two main pieces of data: quantitative and qualitative. And now what I want to do is I want to turn to our quantitative data, and I want to talk about the main sources that we use to collect and use to get quantitative data. And then we're going to look at some of the most common types of analysis that you're going to see when we're looking at quantitative data. And then from there, we'll turn to qualitative. So the types of quantitative data that we often have and where they come from, usually from surveys. We can also think about checklists. So if anybody works in a healthcare setting, probably anybody who does any type of work in a community, you have a checklist of some sort. Have I done this? Have we done that? That is data, right? Our electronic medical records, those are all quantitative types of data. They've got yes, no responses. They've got multiple responses, multiple choice answers, whatever it might be. And so I just want you to level set on that's where we collect our quantitative data most often. And now let's turn to different types of data interpretations. So keep forgetting that this doesn't show the word without the definition, but level setting on a percentage. So this is one that you're going to see oftentimes. These are data points that we saw a whole lot of during our COVID-19 pandemic. And we see it with a whole bunch of data, but a percentage is ultimately, it's a number or ratio that represents a part of 100, right? So if you think about the pie chart on the right side, this is the kind of best way of visualizing a percentage. And so let's just say that we have a classroom of 10 people and 5 of those people in the classroom have diabetes. Who can tell me what is the percent of people in that classroom that has diabetes?
50.
Perfect. Thank you, Omar, right? Because ultimately you're looking at this calculation right here. 5 over 10 equals, oops, get that forward, equals 0.5. And if you remember all the way back into your early days of math, you move that decimal place 2 points over and you get 50%, right? Very simple. So that's what a percentage is. And like, again, I share this because we get shown these data points all the time, but I don't think we're always like aware of what it means. And then this will help us interpret data for our community when it comes time to, right? So I mentioned over here, the pie chart is the most common way of visualizing a percentage. So here we've got individuals in Texas reporting a major depressive episode in the past year by age from 2018 to 2019. You got adolescents age 12 to 17 in this pie chart, adults 18 or older in this pie chart. Can anybody share with me what they observe in these two pie charts? Don't be shy.
Are you talking about the different categories, the age groups, the?
Yeah, just tell me what you see. What are these pie charts showing us? What do you interpret from these pie charts?
That the adolescents ages 12 to 17 have a higher rate of major depressive episode than those over 18.
Yeah, right. So 14.6% of adolescents in this sample reported having a major depressive episode compared to 6.4% of adults age 18 and older. Very simple, right? And so again, it doesn't tell us the why, but it gives us some insight into, wow, there may be something going on here that we need to now address in our adolescents age 12 to 17. And so again, when you think about pie chart or when you think about percentages, your pie chart is going to be the most likely visualization. Julie, I saw that you had unmuted. Did you want to jump in?
I had a question on that. You know, we were talking about how you interpret data, and looking at this on the surface, it looks like the adolescents have a bigger percentage, but what's the whole number? What's the denominator? How many adolescents versus how many adults?
Great question, right? And so this is one of the limitations of a pie chart, in particular this one where they don't tell you the sample size. So thank you so much, Julie, for bringing that up. I don't have the sample size here, but you are correct. This is a question you should always ask. It could be that the sample size for 12 to 17 was 10 kids, right? And the sample size for adults was 1,010. And so that matters because ultimately it tells you the scale of the issue that you're looking at. So let's just assume that these sample sizes were the same because this data comes from, you know, it's a model prevalence based on national level data. So you can assume that the sample sizes are quite large, but it's always a question that you should ask because it's not represented here. So wonderful. Thank you for bringing that up. All right, so that's percentages, right? Parts of a whole. That's what we're looking at when we think about percentages. Let's turn our attention now to rates. So a rate is a number of one thing or an item measured per the unit of another number or item. Who can tell me what is the most common kind of rate that you probably encounter every single day? Interest rate, that's a good one, right? Even more common than that one if you have to commute.
Speed limit.
Miles per hour. Thank you, Deanna. Right. So miles per hour is a perfect example of a rate. So you've got the miles, which is the unit of the one thing, over hours, which is the unit of the other thing, right? And so it tells us how fast that car travels every hour if it's going at that rate. So 35 miles per hour means that a car is traveling 35 miles in 1 hour. That is the point of it, right? So the other common example that we can think of, you guys put interest rates and percentages. I see milligrams versus decaliters, right? There's all sorts of other ones. Another common one that we think about in health is our heart rate, right? So we've got beats per minute. That is a rate. And so ultimately it requires a numerator and a denominator. And oftentimes we use these for like maternal mortality, child mortality, infant mortality. And when we think about it with maternal mortality, it is the number of maternal deaths during a time period per 100,000 live births over that same time period. And does anybody know why we use this number 100,000 when we're looking at usually like maternal mortality or infant mortality or otherwise? Why do we do this 100,000? Yeah, Martha, I think the point you're making is that if we have different population sizes in one county versus another, then we can't just look at the raw number. It comes back to Julie's point about the percentages, right? So if we're just saying that, Bexar County is compared to Hidalgo County, if those population sizes are different, then those rates are going to be meaningless. But we level set with the 100,000 because then that allows us to compare different population sizes to each other, right? And so that's the importance of a rate, is it allows us to kind of see how things vary by population size. So rates are oftentimes most likely visualized using a bar graph like we see on the right. So here we've got pregnancy-related mortality by race or ethnicity 2016 to 2018 per 100,000 live births, okay? So again, you've got white, Black, Hispanic, Asian Pacific Islander, Asian, and this is Alaskan Native, the kind of native indigenous populations here. So any observations about the bar graph that anyone would like to make?
Pregnancy-related mortalities are higher in Blacks.
Not just higher, but almost double the rate
yeah, double
any other
much.
race or ethnicity, right, Sheena?
Right.
So again, it doesn't tell us the why, but it does shine a bright light that there is something happening within this demographic population in particular. And it allows us then to say we need to investigate a little bit further, right? And so again, 41.4 per 100,000 live births across the United States as compared to 13.7 for whites, 11.2 for Hispanics, 14.1. Ismelda, I see that you've unmuted. Did you want to jump in?
No, sorry.
Okay, just fine. Try to always make sure that I recognize where I can see you. I can't see everybody, but I usually when folks unmute, I can see you jump in. So again, this gives us some comparisons across different populations and maybe raises more questions that we want to take a look at. So thank you, Sheena. Yeah, so Susan talks about due to lack of access to prenatal care. There's all sorts of drivers of maternal mortality in the United States, in particular among our Black African American communities. Has to do with some like biases within our healthcare system. It has to do with social determinants of health. But what I want to land on for this piece is that this doesn't tell us that why, but it leads us to ask more questions that maybe we want to collect more data to understand the drivers of that. Yeah, so thank you, Susan. I see racism in there. So let's move from rates to incidents. Now, for all of us that have lived through the pandemic, You guys have seen these line graphs over and over and over again. Incidence as compared to prevalence. You're going to hear these terms oftentimes used in public health because they're some of our most common things. Incidence is the number of new cases, people infected or diagnosed with an illness or condition that develops over a period of time. So in the bar graph or in the line graph over here, so again, this is where you, the type of graph where you're going to see incidence. You can see COVID cases in the state of Texas from the very beginning of the pandemic all the way until January of 2023. Okay, so how does the incidence helpful? What does this help us understand? What can we learn from the incidence data and the graph that you see here? Anybody?
When I first look at it, January 2022, there could have been more access to testing as well. It could also have been there was not enough preventative measures like masking or just other things like that could highlight. So it could mean, I guess, different things.
Right. And to your point, right, it doesn't necessarily tell us the why, but it does allow us to kind of go back and look at what was happening at that time. So it could have been, you know, an increase in testing. All of a sudden, everybody's doing it. What else do we know happened in January of 2022? Anybody?
Novid?
Sorry?
Is that when we had the big
vaccine?
ice storm?
So yes, it was around that time, but there was also something else that was happening, that it wasn't just the Snowmageddon, but there was something else going on with COVID itself.
Everything was shut down.
Well, everything was
Pretty
shut down
much.
over here, right? So that's why you see these kind of lower peaks over here, because we were actually at home, right? We were masking. There was more of this happening. So there's a lot of stuff. So Deborah, yes, thank you. And Rabina, I don't know if you were going to jump in. You want to jump in real quick?
And no, thank you.
Okay. Yeah. So Sheena, everyone's saying it. There was a new strain. So this is Omicron, guys. This is when Omicron came in. So here's when our vaccines were kind of coming along. So we were able to dip this down. New variant, summertime, and then Omicron came along and our vaccines were not ready to be able to handle that, right? So you can see all these peaks. So what it does is it kind of gives us the trends about when people were getting sick and like what was going on at that time. But then you see it completely drop from there on out because now the vaccines had been shifted. They were better targeted for Omicron, and more people were actually taking the vaccines at that time. So again, our incidence rate tells us the new cases, and it can help us understand the trends of what was going on at different points in time, right? So like Sonia says, it helps us monitor the spread of a disease. Okay, that is our incidence. Chan, are you trying to jump in? I just see you've unmuted, so.
No, sorry,
Okay.
I was going to mention Omicron, but.
Yeah, okay, perfect. Thank you. Now let's talk about prevalence. So prevalence is the proportion of a population who have an illness or condition over a specific period of time. So if you think about incidence as new cases, prevalence is all of the total cases over a period of time. And then this is oftentimes visualized with a line graph like this one here. And so you've got cumulative confirmed COVID-19 cases per million. We use our rate here because, again, it helps us level set from March of 2020 until March of 2023. So if we think about prevalence and incidence, what does prevalence tell us that maybe incidence does not? Or what does this graph tell us that may be different or the same from what we saw in the incidence graph? You're all going to be math whizzes and graphic whizzes. Right now, my paper is in prevalent health issues among homelessness. So thank you, Alexandra. Most infectious disease is spike.
I think, can you hear me?
I can hear you. I got you, Janelle.
Oh, okay, yeah. It looks like it's just in totality, like from the beginning until an end measure, which was exactly 3 years and a month. or 2 months, a month. Because if we're saying from March 1st to March 29th, that's what I'm looking at is the prevalent
Yeah.
incidences,
No, so this is
right?
prevalent. So again, I'm going to just quickly go back one so you guys can see this and can kind of compare. So this is incidence rates. You're going to have that kind of ebbs and
Up
flows
and
where it
down.
goes up and down. What this does is it gives you a smoother line to show you the total number of people who have been affected over time. And so what I want to point out here is what this tells you is a couple things. You want to look at what we call the slope of the line. If it is flat, then it means you're not getting a lot of new cases at a certain time. But if it is steep, like right here, so again, this is January of 2022. Look, that line is almost straight up. That correlates with this bump right there. So that's telling you, this is often showing you the rate at which people are continuing to get sick and carry something. But then you can see it starts to level off here a little bit more. And so again, what it does is it gives you that, measures the proportion of individuals that have a disease at a certain period of time, which again, it's really important, but it does tell us two different things, right? And one of the things that I always kind of teach, and I'm going to show this in another graph in just a second, is that sometimes it may be confusing where you see prevalence going up and incidence going down, and that can mean a couple of different things that are going on. But again, this is showing you total numbers of people that have been affected by a condition, in this case, COVID-19. Okay. Yeah. True positive slope. Love it. You guys are all experts. All right. So my slides are all wonky. So let's look at one more example, because this is the point that I was just trying to make. Is so if we look at these two graphs, this is trends and incidence of diagnosed diabetes, adults age 18 or older, 2001 to 2019. So this is incidence on the left, prevalence of diagnosed diabetes, undiagnosed, and total diabetes in the same population, roughly the same time period. Incidence on the left, prevalence on the right. Any observations that folks would like to make here? Yeah, so Blanca says that there's a spike in 2008. Could have been anything, right? Could have been an improved reporting. Maybe there was a new test out there that helped people kind of get a better, more sensitive diagnosis. So Susan says prevalence trends up. And what's happening with incidence then, Susan? I'm going to put you on the spot.
Going down.
And so what does that mean? If incidence is going down, but prevalence is going up, what does this tell us?
It means
You
there
don't
are
have
less people infected, less people have that, but overall more people experience the complications of diabetes, maybe.
Great. Anyone want to add to that? Sorry, I keep putting you on the spot, Susan, but you're doing great. Anyone else want to add to that? So there's a couple things going on in the chat. Somebody said, Sheena says, I would have thought the undiagnosed number would have been higher, right? Yeah, you would definitely think so. And again, like, how do you actually, I'm curious about this kind of measure, because if it's undiagnosed, then there's probably even more people who have just never gone to the health system, but we can leave that for now. What this shows us is interesting, right? So we've got incidence going down, which is an indicator that our health education and maybe our preventive measures are doing a good job of preventing new cases. But if our prevalence is going up, then what this shows us is that people are living longer with a diabetes diagnosis, right? So this is that kind of counterintuitive piece that we want to think about, because what this shows us again is the number of people that have the condition. If somebody dies, then they no longer have the condition. And so oftentimes what you would see earlier on with a diagnosis is that people wouldn't live as long because they would have so many complications. But because our treatments are getting better, because we're getting earlier diagnosis, we can help people live longer, fuller lives. Thus, the prevalence goes up and our preventive measures are working. So incidence is going down slightly. Does that make sense? Awesome. All right, so keep those in mind. Those are kind of the things that you want to think about with the incidence and prevalence. All right. A couple other quick terms that I want to just level set on. Morbidity and mortality. Who can define these two terms for me? Because we love using these two terms in public health. What's morbidity and what is mortality? Anybody?
Mortality means death.
Yep. Thank you, Sheena.
And the other one is sickness, right? Oh, well, I see it in the chat now.
Yeah, or illness.
Yeah, perfect.
Or injury, or injury.
Yeah, you guys are doing great, right? So morbidity is like living with an illness, a condition, an injury, whatever it might be. Mortality is a way of describing death. And I just want to level set on this because, again, we use these terms, mortality rate, morbidity rates, but we don't oftentimes explain what that means, particularly when we're talking to our communities. And I want everyone to understand those two things. And as Sonia points out, both of them are used in epidemiology. And so, again, I want you to know it so that when you see data, you can help our community understand what does this mean and what does it tell us. Awesome. All right. So that is our quantitative primer. Let's talk about qualitative data very briefly, because again, this is an entire, like I could spend an entire semester teaching folks on qualitative data. But what we're going to do is we're just kind of level set on the different types of sources. And then I want to show you how qualitative data are generated and then analyzed. So qualitative data are words. They can't necessarily be counted. There's a variety of different ways that qualitative data can be collected. You can conduct interviews, which is a one-on-one conversation. You can have a focus group discussion, which is a group discussion, right? So you have maybe one facilitator and a group of 10 to 15, no more than 15. 15 is actually a pretty large focus group. What I do want to level set on for folks, because you may get asked to recruit people into a focus group, and it's good to be able to explain what it is. A focus group is not a group interview. Right? It is not meant to be, all right, I'm going to ask Martha this question. Now I'm going to ask Betsy this question. Now I'm going to ask Susan this question. And I'm going to ask Omar this question. That is not the goal of a focus group. The goal of a focus group is to have the interaction and the conversation between participants about common themes and ideas that you as the researcher are looking for. If all you're looking for is individual responses to questions, then you're better off doing an interview, right? You're looking for the diversity of thoughts and opinions in a focus group. Sorry, it's my little soapbox. I always like to make sure I say it because sometimes people think, oh, I'll just get 15 people together and ask them all the same question. Not a focus group. Storytelling practicas are another way of looking at qualitative data, right? It's not always like me or you asking questions, but just simply hearing people's stories and getting them to talk about ideas and thoughts and reflections. That is qualitative data, whether you're capturing it intentionally or not. And then document reviews are also a form of qualitative research, right? So you can collect diaries, journals, you can look at project proposals, you can look at policy creation at a legislative level, and all of that can be qualitative data that you can analyze. So let's assume that you have collected your data in one shape or another. The way that qualitative data are generated is by listening to people's oral stories and putting them into a written story through what we call a transcript, right? So I conduct an interview today. I listen, I record that interview, and then I turn it into a written transcript of the conversation that we had. As I look in that story, I'm looking for words and phrases that kind of continue to bubble up oftentimes, right? And so I'm looking for those repetitive ideas because those words or phrases that keep being repeated ultimately become the themes, or as Susan puts out, the key words that are going to draw us back to the idea that the person wanted to share, right? And so these are the data that get generated from a qualitative research project. It is the constellation of all the words and phrases from different stories, the main ideas that cut across those multiple stories, those themes. That is what you're looking for in qualitative research. And so you want to sometimes look for the outliers, right? So you're not always going to find commonalities across your different stories. Sometimes it's the person that veers off to the right that has a theme and or idea that is really important to capture, but you'll kind of know that when you see it. But at the end of the day, you're looking for what we call congruence, where all of those themes are kind of coming together, and then you're going to describe those themes and how they interact with each other, right? So maybe one theme is fear of the healthcare system, and another is a feeling of disease burden, whatever it might be. And I'm going to give you an example of how we do this in just a minute, right? So bear with me one second. So I wanted to talk a little bit about transcripts because this is your main source of data and qualitative research. So the steps to reviewing a transcript, and this comes from the authors Braun and Clark, it starts with becoming familiar with the data. So as a researcher, you're going to read those transcripts, you're going to listen to the recordings if they exist, you're going to make notes, lots and lots of notes, and you're going to start thinking about what are the things that I've heard, and you're going to write those themes down. Then you're going to go back and you're going to read and listen again, and you're going to look for those themes intentionally. You're then going to review, did I actually look at those themes in the right way? You're going to ask somebody else to review those themes to say, hey, do I feel like I'm on the right path here? Do you hear the same thing? Do you hear something different? Once you have some sort of an agreement, then you're going to define them, give them a definition, give them a name, and then you're going to talk about the interpretation of how different themes talk to each other. And again, I'm going to show you an example of this here in just one second. So again, this is a primer. I don't recognize that anybody's going to come out of this with the ability to do this on your own, but I want you to understand the process. So these are two phrases that I've taken from my own research in the past of some interviews that we conducted. I'd like you to just take a look at these, read through them real quick. And I want you to start thinking about what are some of the themes that you observe when you're reading this transcript? What are the words or phrases that kind of jump out at you as kind of important things around health and well-being? So just review, don't share anything yet. All right, in the sake of time, for those that would prefer this in Spanish, I've got a version here in Spanish. I'm going to dwell on this for a moment. And for those of you that are working on your Spanish, feel free to review and start brushing up on your Spanish. So before I move to the next slide, anybody want to share something that jumps out at them about these two stories, these two pieces of transcript?
I'm going to say probably just both being affected by COVID-19.
Yeah, so there's an effect of COVID.
Mm-hmm.
Ismelda says delay of care. Betsy talks about transportation. Denise talks about COVID being overwhelming, so other issues were ignored.
Pretty much like access.
Yeah, exactly, right? So Elaine says that as well. Access to care is an issue, right? Marquita says the same exact thing. And so what I want to do is I want to show you the highlighted text of 3 themes that we identified as a team when we were first reviewing these. So and again, these are aligned. So the red is kind of a similar theme, the blue is a theme, and the green is a theme. So in red, we have now my diabetes is so out of control and I feel sick every day. Down here, we have last month he had a heart attack because he refused to go to his annual doctor appointment. Any thoughts on what this theme may be that we highlighted here? Out of control. Yeah, Sheena.
I guess due to both not being able to get into their doctor, it really affect their health.
Mm-hmm. Yeah, and then if you look at the blue one, right? So my doctor cannot even see me until next month now that the clinic is open again. So Sheena, I would almost say that is your access code, your access theme, right?
Mm-hmm.
And then the red is like the impact of a
The
lack of
impact,
access,
yeah.
right? And then the green, he was afraid they would force him to get the vaccine. So then there's this kind of fear theme, this kind of anxiety theme that emerges. So when we were coding these and we were coming up with our themes, our red we called loss of control of health. So because they lost access to healthcare, they lost some control over their own health, right? And Susan even calls it a challenge to get an appointment due to backlash, right? So again, we simplified that down because loss of access helped us kind of look at other common issues. But then here in the green, we had lack of trust. And so part of it was this person didn't want to go because they were afraid that they would get forced to get a vaccine if they went to the clinic. So again, you can begin to see this interaction between your different codes and how one piece, access, leads to loss of control, or lack of trust leads to loss of control because you then don't feel like you can go and get the thing that you need done. You guys are all now expert qualitative researchers. I will send you transcripts. You guys can help me code them all. No, I'm joking. But again, this is just meant to be a primer. Whenever you read anything, your brain is automatically beginning to code things, to put them into themes, to make sense of it all. All this does is it gives you that that structure through which you can begin to organize your data. I just want to call out, Antonia puts in the chat, fuera de control is a strong statement in Spanish. Is there something that you want to add to that, Antonia, for us? Don't want to put you on the spot, but. Okay. That's it for qualitative. I wish I could spend more time on it, but it gives you at least an idea of how we get from words, stories, to common themes, to then some sort of an analysis of what it means. So we're into section 4 now. I'm going to take a quick break and drink some water. Thank you all for your participation and comments up until now. We're kind of coming to the end here. Still probably have another 15-ish minutes, so please stick with us so you can get your continuing education units. But let's look at some common data visualizations and really try to synthesize, in particular, the quantitative data that we've been looking at together today. And so I want to start with some kind of key health indicators focused on diabetes, cancer, maternal health, and access to care to show you the way that data can be shared in reports or even with the public, and to help us begin to understand and interpret that data so that we can then be the best advocates and utilizers of data when we get there. All right, here is chart number 1. Everyone get ready, take a deep breath, because there's a lot packed into this chart. So to begin with, we start with, what is it? It's the prevalence of diagnosed diabetes, adults 18 or older, by income and sex from 2018 to 2019. So a lot of data here. On your left, on your y-axis, you have the percentage, right? On your x-axis, you have income level, less than 100% of the federal poverty level, 100 to 299, 300 to 499, greater than 500%. And then your color of your bar graphs, total, orange is women, gray is men. A lot of data packed into here. All right, so Alexandra has already taken us off on the interpretation. So what she says is women are slightly lower than men. What else do people observe when they see this bar graph? Help us interpret what is the data showing us. Right, so Sheena points out that the only variation of what Alexandra said is that the lowest poverty level, or the got that wrong, highest poverty level, women have a higher rate of diabetes than men. So what do we think? What's going on here? Somebody help me interpret this. So we've got people with higher income levels most likely have access to a doctor or care, right? So there's greater access to care potentially. But does care prevent diabetes? What are some of the drivers of diabetes? You know?
The drivers are the things that we put into our bodies, right? So if you don't have that much more of resources, your family's still going to eat, right? But they're not eating the most healthiest that they possibly could, is what I'm gathering.
Yeah, great. Sorry if I put you on the spot. If you were going to say something else,
No, that's
feel free.
fine.
Yeah, you guys are nailing it, right? So there's access to food, there's the ability to exercise, right? It's like, what are the type of food that you have? Do you live in a neighborhood where you have access to different types of food? So the higher the income level, the likelihood is that you have greater access to those things, right? But not only that, but why is it that men outside of this highest poverty level have higher rates than women?
Are they less likely to be compliant?
There's probably some health-seeking behaviors there, right? And so like men are known to be less likely to visit a doctor, right?
That's my father. Yes.
Yes, I was gonna say that.
Or take medications. My husband is not a pill popper.
They don't
Exactly.
follow orders. They don't follow their orders.
Hey, I take offense to that. No, I'm just joking. But you're right. I mean, there are differences in terms of behaviors between men and women that cut across income levels, right? Yeah, I'm just reading what everyone else has in here. There's also insured versus uninsured that Robina talks about. Very important when we talk about the income levels. I love what Omar is saying. Maybe the work hours determine doctor visits, right? So it could be that in these populations, men are the breadwinners. They are working in the household. And I'm not saying that this is necessarily true, but it could be. And so they have less time to eat healthy. They have less time to be physically active. They can't go to the doctor because of that. Or it could just be, as Alexandra says, men are stubborn, right? So again, what this data does is it gives us this picture of what is potentially going on. And it says, okay, clearly there's a relationship between income and diabetes. There's also a gender piece to this. And maybe we need to then go ask some more questions to understand the why of what is driving this difference, right?
Genetics. And people are just saying, oh, I'm going to get it anyway. This is going to be my life. Maybe they take the medication, but they still eat crappy. Does it give us that information?
No, because it's all hidden behind those demographics, right? And that was my point of when we do this kind of research, and you as a consumer of this research need to ask that question. Well, what doesn't this tell us? And if it doesn't give us that, then that's when we go and maybe do a survey with these men. Let's understand what's going on here. Or we do interviews and try to understand the why of what is driving.
Or the focus groups.
Yeah, right? Yeah. Julie, did you want to chime in?
No, I was still looking at the below the FPL group and just wondering, and I think somebody said it in the chat, it's quality of the medications too. When I was with Denton County Public Health, we were managing some folks in that particular group with plain old insulin and metformin. And, it takes a lot of education to get somebody to control their diabetes with insulin and metformin. Whereas, the people in the other groups, they get a pen that auto doses for them, and it's super easy. Very little education is required there. And so there's that piece of it as well. And what physician has time to sit down with a patient for 30 minutes and explain how insulin works?
Yeah. Huge part of this, right? I mean, there's all sorts of factors kind of nested within this. So I appreciate you mentioning that. Yamsita, I see your hand. Yamasita, sorry if I misspelled that or said that.
Oh, you said it perfectly. Thank you. Okay, so My comment is probably a little bit different, because I'm looking at this chart, and because we're all data-driven people, but we also know that there are disparities that are present even within our diagnosis procedures. And so when I look at this, I also wonder if it's possible that individuals who have lower income and they may be going to a clinic where they are not don't have an established doctor for the past 20 years, things like that. So if they have that A1C that's high that one time, they may get that stamp of diabetes diagnoses, and they really do not have diabetes. And so, when I look at the
Yes.
income, when I consider that, that's just something that I think about. And so it's like we may be pushing this, but is this really a true snapshot of a chronic disease process? The actual presence of
Right.
that chronic disease process.
Yeah, no, I appreciate what you're saying, right? I mean, it's all about the definitions and it's all about the data that goes in. So I'll just tell you, and I'm not going to defend or criticize the data just because it's drawn from the CDC. It's a National Diabetes Statistics Report. So I think, we always have to take it with some grain of salt to say, is it an accurate representation? Do we have people within here who are pre-diabetic but have been put in here? Those are the questions that are harder to answer. But again, I'm just happy to hear you all engaging in the conversation to say, what more do I need to know and understand than just the graph being presented to us? Because too often we take it and we just say, that's what we have.
Yes,
I
thank you.
also had wanted to add something, and Yamasita brought up a very valid point, and I'll use myself as an example. They stated, I went for my annual this year because I'm trying to do better, and they said, "Oh, well, your numbers look like you're at the pre-diabetic stage, so we're gonna put you on and exactly what you said, metformin." And I said, absolutely not. How about you direct me to nutrition, instead of pushing, medication? How about I didn't know that I was stressed out at that point in time, and that may have increased my A1C numbers, right? I didn't know that until I asked questions, because I did not realize that stress was an indicator of, okay, my gosh, my morning was going horrible. I was trying to get in here. My hip is hurting. I'm trying to walk as fast as I can. Now my blood pressure is up. So now they say I have high blood pressure and diabetes, but it's pre-diabetes, right? So I don't know.
Yeah. Well, I appreciate you sharing that, Janelle, because again, there's people's lives in these data here, and you're sharing yours there. And again, yeah, we don't know whether or not is that one-time diagnosis, if it's multiple times. That's where, again, I'm happy to share these kind of slides and notes, and you guys can dig into where they get the data and what are those sources, because those are the questions you should always be asking when you see data. So thanks, guys, for all the conversation. Let's move along. I got a couple more examples here. So here we have county level diagnosis of diabetes prevalence, adults 20 years or older, 2004, 2012, 2019. So light blue is the prevalence 3.3 to 6.5%. Dark blue is the highest prevalence 10.1 to 19.5%. So this is to show you that you can look at the data in a lot of different ways. So this is showing us county level data across the United States at 3 different time spots. What observations do you guys make?
We are losing the battle.
Yeah, so Omar says, to Julie's point, there's an overall kind of general increase in diabetes across all counties in the United States. Any other observations?
There are definitely regions or areas where it is more prevalent.
Can you give me one of those?
In the southeast.
Yeah, so we've got this whole area here, kind of the Alabama, Louisiana, Arkansas area, North Carolina, Georgia area. I'll tell you.
Those are states
Go ahead.
generally that have higher levels of poverty, if I'm not mistaken.
Right. So now you're extrapolating to other data that you know of, right? So we typically like we know that the data in the Southeast typically kind of lower income, as Phyllis points out, more African Americans in those communities. And so we're starting to see the layering of issues that are going on here. One of the things that I wanted to point out when I first saw this, and I was kind of surprised, is way up here in the Northeast has really high rates of diabetes prevalence as well. And as Mohammed says, it could be explained by the increasing number of diabetes tests, right? So yes, there's a sensitivity there about the more we test, the more we get, but it also kind of shows that there's a relationship between where we live potentially and a risk for having a diabetes diagnosis. So it's related to food insecurity, it's related to poverty. There's a relationship with race and ethnicity again, but that's like baked up into the socioeconomic issues, lower access to healthcare that we know of, right? The Texas border region has high rates. Unfortunately, for those of us that live in Bexar County, we've got really high rates. And then as Omar says, the Southeast dropped from 2012 to 2019. So just lots of trends. It raises questions for us and gives us some data that we can begin to kind of unpack. So, all right.
Well,
Janelle, go ahead and then I'm going to move us on.
I'm sorry. Was it a lot of, and I'm looking from 2004 all the way through 2019, like the numbers change drastically, like over the years, instead of health and the well-being getting better for individuals, it's declining.
I think unfortunately you're seeing that trend, right? I mean, and again, it's this compounding factor, I think, is what we're saying, of a whole bunch of different factors: income, access, food quality, life stressors, all of those things in those communities. Yeah, Jessica, jump in and then I'm going to move us on.
So I was thinking about, like, again, going back to like the policies, like the public health, proposals and stuff. I'm going to that, sorry. And I know that I read, or from the webinar, it said that, like, like it should be more like, okay, again, this is great, honestly, but like it should be like the secondary, I guess it's secondary data, like when it comes to, like, when you go in front of, I guess, stakeholders. I just found that fascinating because it goes back to the assessments and, actually talking to the community and finding out that. I'm kind of all over the place, so I'm sorry. My words aren't always that great.
Well, I think the point you're trying to make is right. So we get this data, but then it kind of behooves us. It's important for us to go and dive a little bit deeper in the communities that we particularly serve, because these are generalizations, right? These are aggregate data. They don't tell the story of exactly what's happening on that one block or in that one neighborhood. And it could be that in that area, it looks different than the trends across the entire county. And so I think that's where you have to begin to look at different data and understand the specific needs in the populations that you're serving.
So much, huh? Wonderful. Yeah. For that thing.
All right, I got a couple more of these and I want to make sure we're on time. Gosh, I got 15 minutes left, taking much longer than I anticipated because you guys are awesome. So let's look at trends in colorectal cancer incidence, 1975 to 2013, and mortality by sex across the United States. So here we got colon cancer. You got mortality on the bottom, red for women, blue for men, and we've got incidence rates. So again, incidence being number of new cases up top, red for women, blue for men, rate per 100,000 years down here. Any observations? Marquette, I'm going to, go ahead. Susan, Julie, I think one of you guys were going to jump in.
I just find it interesting that there's no incident rate before 1975.
Yeah, does anybody know why?
There was no
we
something
were,
to measure it.
Yeah, there was no screening. So all of a sudden you go from no screening to screening, and what happens? Incidence goes up. This is the point that you guys have been making in the chat. When you begin to test for something, you're going to see more of it, right? And that's okay. But the beauty of it is what this shows is that once we start to do the screening and within 10 years, incident rates begin to drop significantly. What else?
my made a difference.
I'm sorry, you kind of broke up there, Julie.
Screening definitely has made a difference.
Right.
So catching it early and being able to treat has helped mortality as well.
Exactly, because look, right? So here's where you begin to see the dip in incidence. It's the same way that you see mortality is kind of holding steady. 10 years later, you begin to see mortality drop. And that is because we're getting earlier screening. People are getting their diagnosis earlier. And we know with cancer, the sooner you get a diagnosis, the more likelihood of having a successful cancer treatment, right? And again, I think we generally know that men are at greater risk for colon cancer than women. And there's a lot of different reasons for that. But again, this is what's interesting to think about when you look at the data, and I'm glad that they put incidence and mortality together because it gives you that holistic picture of what was going on. All right, in the interest of time, I'm going to keep us moving along. I'm not going to dwell on this slide. I do want to look at just maternal mortality very briefly. I'm going to look at, actually, I'm going to look at this slide rather than the other one. So this is looking at pregnancy-related mortality in Texas in 2013 by race and ethnicity. We've looked at this data before. Again, it shows us the pregnancy-related mortality ratio per 100,000. We see that non-Hispanic Blacks have the highest pregnancy-related mortality in Texas. It's due to a lot of factors that I think we can unpack at another time because I want to keep us moving along. But I just wanted to show you the kind of different ways that data can be visualized and we can interpret it. And then it raises questions. So it doesn't answer the question for us, but it gives us a signpost through which we should look. Last data point, and then we're going to talk about collecting and using data. Insurance coverage. So the number of uninsured by county, dark blue being 25% and above, light blue 10% and below. Again, I don't think anybody, well, hopefully nobody is shocked because we live in the state. We don't have Medicaid expansion. We don't have a whole lot of access to health insurance in our state. It's actually kind of shocking to see how different we are from the rest of the United States. But you can see that border counties and panhandle counties have the highest rates of uninsured as compared to other parts of the state. So lots of issues that are kind of driving this. We also have high rates of migration and immigrants living along our border communities, which increases that uninsured rates because they don't have access to those services. All right, let's land on a couple roles and responsibilities. So when we think about the roles that you as community health workers may or will play in data, oftentimes you're asked to collect surveys. So they say, hey, you got access to a community, help us go out and collect those data, help us conduct the interviews. You speak the local language, you understand the cultural context. So go conduct those interviews. Help us translate them. Sometimes you're asked just simply to connect people to researchers, right? So like somebody says, I've got a topic, I need men and women within this age range, please go help me find these individuals. And when these things happen, what I think is really important is that you have a role and responsibility to ensure adherence to ethical practices. Are we sampling the right people? Are we consenting people in the right way? Are we providing our consent and our surveys and everything in the language that people speak? And this is the power that you have when you get asked to participate. You should be asking these questions to make sure that the data is being collected in the most appropriate way and with as little bias as possible. But you not only get involved in collecting research, but you can use it, right? You've talked about this, identifying the needs of and opportunities in communities, prioritizing strategies, right? As the tip of the spear, you're out there saying, this is the need in the community. Let's bring this program here. Let's not do that program there. You become a community advocate. These stories, these data are how we tell our legislatures and policymakers the why programs are needed or why policy changes are needed. And also, like, you can bring those stories and recognition for the things that are happening in a community. This is the one slide on ethics because we just don't have a lot of time. Elaine, I see your question. IRB it's an institutional review board. It is an ethics oversight committee for doing ethically responsible research. All academic institutions have them. Some exist in communities, but they also make sure that we are using the right language when we do surveys, that we are collecting consent forms and telling people how their data will be used and whether or not they're going to be confidential or anonymous. And part of, I think, the role that CHWs can play that doesn't get used as often as it should is making sure that the data are collected go back to the communities from which they were collected in the first place. Oftentimes what happens is we collect the data, we write a manuscript, we then pat ourselves on the back because we went to a conference, but then the communities from which that data was collected have no idea what was shared, what was taken from them. And so part of the role that we can play as community health workers is making sure that we advocate for and then bring that data back so that they can see themselves. Because again, remember, data are people and their stories. All of the data that we've looked at are aggregated, but each one of those data points is somebody's life. And so we need to add value and respect to those things so that we can make sure that people are seen and acknowledged for the knowledge and the expertise that they share with us. So again, there's so much more that we could do and have conversations around with data, but I've taken up way too much time, and mostly because we've just had a wonderful conversation. So I appreciate you guys engaging with me. Some of the data sources that I've used here today come from the CDC, Community Health Needs Assessments. Kaiser Family Foundation has really good data visualizations, nationally speaking. Texas DSHS has some great data. There's all sorts of other places to get data. And so I wanted to just pause here and say thank you, see what questions you might have for me, and then also move away so that Cheyenne can put up the end of program survey, because I'm sure many of you are waiting for that one. But any questions, anything you would like me to clarify while Cheyenne is pulling up the post-session continuing ed?
Everyone, I'm putting it in the chat box for now, and then there will be a QR code in a second.
Dr. Rosenfeld, do you find one type of data more difficult to analyze or than another?
Yeah, it's a great question, right? So the way that I kind of teach our health profession students is that quantitative data collection is the most time consuming on the front end because you need to design a valid survey. You need to make sure it's in the right language. You kind of need to know what kind of analyses you're going to run. But then on the back end, you know, there's statistical software. You push some buttons and you get some statistics, you get your rates, etc. Qualitative, on the other hand, is relatively quick and easy to stand up, right? Because you design your interview. It's usually fairly open, but it takes a much longer time on the back end to analyze because of that process of reading, reflecting, creating your themes and otherwise. And so that's kind of the way that I view both of those, whether one is easier than the other. I mean, I love reviewing qualitative data. I just think it's rich. I think it's much more interesting sometimes than running statistics, but that's my own bias.
Thanks.
Mm-hmm. So Cheyenne has put the QR code up. There's also the link in the chat for those that were asking. I'm going to copy from what Cheyenne had put in and I'll put it back in here.
I have a quick question.
Yes.
Yes. So can we use both data, or which one do you recommend to use?
Please. Yes. Great question. I am an advocate of what we call mixed methods research, which is where you do both, you use both data at the same time, right? So if you've got, again, we were looking at so many graphs and charts, but there are questions that emerge when you look at that data. But if you can combine that quantitative data with real people's stories that explain the why of what you are seeing in that data,
Right.
it's so much more powerful. And so I recommend to folks, when and where possible and feasible, you should try to do both quantitative and qualitative data.
Combine the two. What is percentage we can use for both?
It just depends on the study and the question that you're asking, right? I mean, because it could be that this data already exists, so you're going to use national level data, but then you're going to go collect some qualitative stories of the specific population you serve, and those stories are going to explain the quantitative data that you have. But it could be that you don't need all of the qualitative and you need to just collect 100 surveys. It just depends on the question. So it's kind of hard to give you a hard and fast answer.
So it's good to use both, a little portion of both data to have a quality research.
That is my approach to it, and I think most people will agree these days. But there are some folks who live in quantitative research, and they don't necessarily do a lot of qualitative or find the same value that I would. But everyone's a little different.
Right. Yeah. Just to compare the two and know you have a quality information. I think I'm also agree that it's good to use both.
And again, you don't have to like go crazy with this, right? Your qualitative research can be a couple of quick questions that you ask folks, and you're just going to use those stories to explain something. It adds value and richness to data that you wouldn't otherwise have.
Right. Okay. It's a good thing. Thank you for your time. We really enjoyed the class.
Well, thank you for your participation. Thank everyone for their participation. You guys make this as engaging as it is. So I appreciate you all for asking great questions and sharing your own experiences.
Thank you. Have a good day.
Yeah, thank you. You too. For everyone else, once you've completed the survey, we thank you very much. Next month we will be hosting. Is it Shan? Are you up next?
That's a good question. Let me call off video and say hi to everyone. Because I also want to share my screen again to share what some of you may have missed in the beginning. I'm just going to look at the schedule. Yeah, I'm next. November 21st. So Thanksgiving is late this year if you're in the US. So we will not be interrupted. And so that'll be on project evaluation. And then I just want to, so continue using that link in the chat, but I want to show everyone what it looks like on the screen. So make sure that when you complete the survey, you choose data use for CHWs. If you choose one of the other ones, you will not get a certificate. And then you just have to complete the survey by next Wednesday so that you'll receive it later next week. And yeah, I've been fielding a lot of questions about missing certificates for the role of CHWs in public health. So that one was sent out August 23rd, and it would have come from someone with the email ending in Cardea, CARDEA services. Sorry, I'm going to stop the recording if we're still recording. And then